that. It looks like we are having everyone in with us today. I'm going to give it one more minute. And Caitlin, if you could just let me know if we're definitely ready to get started and then we have everybody admitted from the waiting room.
Yeah, you're good to go.
Great. Thanks, Caitlin. So again, welcome to our webinar this morning. My name is Mary Beth Shadweski, and I will just be helping moderate the webinar today that's being hosted by the American School Health Association. Our mission is to transform all schools into places where every student learns and thrives. The American School Health Association, or ASHA, envisions healthy students who learn and achieve in safe and healthy environments, nurtured by caring adults, functioning within coordinated school and community support systems. If you aren't a member, we would encourage you to become a member for ASHA, and there is multiple benefits for becoming a member. You would be able to receive the Journal of School Health, which is ASHA's peer-reviewed index professional journal, and it's available to be printed and or accessed via an online source. There's always continuing education credits. You receive free education credits, including the Josh Shelf studies, attending webinars, and or via attending annual conferences. There are CEU credits available for today, and we will get into that at the end of the webinar on how you can get those CE credits. There's also discounts. There's discounts on select AAP publications, as well as a discount for materials from the Sex Ed Network, and there's also the ability to see job postings on the Career Center. And additionally, there's a ton of expertise and information available to you from other ASHA members, the ASHA website, where you can access the latest school health information by attending our annual conference and the bi-weekly newsletter that goes out. And just to speak briefly about our upcoming annual ASHA conference, just like everyone else, we are going virtual this year. And the ASHA conference will be held on September 30th and October 1st. Registration is now open, and you can register for the conference via the ASHA website if you go to the events page. And we are hoping to be back in our plan of Albuquerque, New Mexico next year in 2020 from October 6th through the 8th. So again, if you would like more information about that, please visit the events page on the ASHA website. I definitely would like to now switch gears and get into our information today that's going to be provided to us by Marie Malloy. She is the Volunteer and Community Engagement Director at Food Allergy Research and Education. She joined FARE in 2015 and has held several different positions within the education department. Prior to joining FARE, Marie spent a decade at the Cornelia de la Sang Syndrome Foundation, working in public affairs, then organization management. And Marie is the parent of a teenager who has multiple food allergies. And with that, I am going to turn it over to Marie. And Marie, you'll need to unmute yourself.
There we go. All right, let's get this on the screen and then. All right. Boy, there's something weird about looking at yourself in the corner of a presentation on film. Hello, everyone. Thank you for having me today, and thank you for joining and learning more about food allergies. As Mary Beth mentioned, I've worked for FARE for just about 5 years now, and I'm the parent of a 17-year-old going into a senior year in high school who is allergic to sesame, cashew, and pistachio, and has outgrown allergies to peanut and other tree nuts over the years. So food allergies is not just what I do every day, it's what I live every day as well. So I just want to let you know that this is not meant to be an in-depth medical or allergy management focused presentation. This is a basic overview of food allergies, hitting on several key areas, including the school setting because of the audience. And we'll definitely give a nod to COVID when we get to that point. And if you're interested in more depth information about research, treatment, management, 504s, and I'll remind everyone there's a 504 webinar coming up. We have a webinar library that you can access anytime for free, and I'll be sure to share that information when I share some details with Caitlin to follow up with everyone. So like with any good webinar presentation, we start with our disclaimer and liability statement. You know, what we have here is not meant to replace medical advice, diagnosis, treatment, legal advice, and different things like that. Everything I'm doing here today is the most current information that we have. It doesn't mean it won't change tomorrow. So at the end of this presentation, you should be able to understand the prevalence of food allergy and distinguish what a food allergy is and is not. What to do when there is a food allergy reaction that you are around, how to avoid accidental allergen exposures, and also for this audience, how to keep students safe and included in the school setting. Just a quick 411 about FAIR. If you're not already familiar with the organization, it's been around for a long time, formerly known as the Food Allergy and Anaphylactic Network. It was changed to FAIR several years ago, a couple of years before my time. And the mission is simple: to improve the quality of life and the health of individuals with food allergies and to provide hope through the promise of new treatments. And currently we are the largest private funder of food allergy research in the entire world. We have tons of educational programs and resources, awareness campaigns like Teal Pumpkin Projects and Food Allergy Awareness Week, advocacy initiatives, and research. And all of these resources are available for free, and you can download them right off our website. So what's a food allergy? A food allergy simply is when your body's immune system reacts to a food protein and they think it's a threat, so it attacks it. And that attack, that response, is what is known as the allergic reaction. They can be life-threatening, and they can develop at any age, including adulthood, even if a person has previously eaten something their entire life. There's no rhyme or reason to when allergies will start. Some people are born with them, some develop them as teenagers, some develop them as adults. Sometimes they go away, sometimes they come back. I think until we truly understand why food allergies happen, you know, we won't truly understand why they happen at different times and why they go away and come back and things like that. Food allergies are confirmed through blood, skin testing, and a clinical history. And doctors will say the gold standard is that you have a positive impact of all three of these. So you have blood tests that shows there's an allergy. You have skin testing that shows there's an allergy. And you've actually had a clinical history, meaning you've had a reaction. Without having all three, you can never be 100% sure that there is a true IgE-mediated allergy existing. And that's why they have oral food challenges, I should add. A lot of times, if doctors are unsure, they'll do an oral food challenge. So food allergies are not going away. In fact, they keep increasing. This is an infographic that was created several years ago when Dr. Ruchi Gupta in Chicago, one of the gurus of food allergy research, did a prevalence study. And we had thought all along that about 15 million people had food allergies, but in fact, it was more like 32 million. And that's 1 in 10 adults and 1 in 13 children And of those people with food allergies, more than half of adults have had a severe reaction, and almost half of children have had a severe reaction. And interestingly enough, when you look at anaphylactic diagnosis on insurance claims nationally between 2007 and 2016, there was an increase of almost 400%. So, you know, it's definitely increasing. And recently we did a study that looked at beyond regular IgE-mediated food allergies. And what was discovered was that the impact of food intolerances, food allergies, was something like 85 million people were impacted in their consumer habits and daily living. So the word food allergy is sometimes used as an umbrella. If people don't understand exactly what it means, they'll say, oh, I have an allergy to this or an allergy to that, but they really don't have an allergy. There's several different conditions and diseases that people have reactions to food, not anaphylactic, but they are nonetheless not pleasant and can be dangerous. So food intolerance is a reaction to food that does not involve the immune system, like a food allergy, and it's not life-threatening. So an example of an intolerance, or you may call it a sensitivity, is lactose intolerance. That's pretty common, and that's when a person can't digest lactose, which is the sugar in milk. Other common intolerances can be gluten and beans and chocolate, and some people have sensitivities to different additives that go into food. And you know, the difference between intolerance, sensitivity, and a food allergy is you're not going to have anaphylaxis. It's not life-threatening. And while it may be uncomfortable and there may be digestive issues, you know, it can't be fatal. Celiac disease is an autoimmune disease that damages the small intestine when a person consumes gluten. And this is a very serious disease, and there's long-term health consequences like dental issues, infertility, and lots of digestive issues, but it doesn't result in anaphylaxis. A couple other conditions you may or may not have heard of, eosinophilic esophagitis. You can say that fast 3 times. We prefer to say EOE. That's when a large numbers of eosinophils, which are the white blood cell type things, gather in the esophagus, and they cause the esophagus to swell, and it's very difficult to swallow food. It can be very uncomfortable, and often that is triggered by food. And if you've heard of something called oral immunotherapy, which is a treatment for food allergies in which people eat small doses of their food over a course of time, what they have found, and I think there was a study just this week that came out that said something like 2 to 5% of people who go through OIT actually will end up with EOE. So there's more research going into that as well, because that can certainly be an issue. Some people with EOE have it so badly that they need to be tube fed and actually cannot ingest food, or they can only eat a couple different things. FPIES, food protein induced enterocolitis syndrome, is a food allergy. It's non-IgE mediated. It's typically found in babies and toddlers, and common triggers are oat, milk, soy, and it causes excessive vomiting and diarrhea, usually about 4 hours after ingestion. And while there's no anaphylaxis, it can be very dangerous because it can cause dehydration and also a condition that looks a lot like sepsis. So it's definitely a serious condition. And then oral allergy syndrome. A lot of people will eat an apple or a peach and suddenly their throat is itchy or their mouth is itchy, and that's OAS. And typically it happens in people who also have hay fever or any kind of seasonal allergies, and occurs in eating raw fruits and vegetables. In very, very rare cases, it can cause anaphylaxis. And some people who have a food allergy also have oral allergy syndrome because of the cross-reactivity between, say, for instance, a certain nut in a certain fruit, like some fruits with pits, stone fruit, are related to certain tree nuts. So sometimes if a person is allergic to a cashew, they may have oral allergy syndrome to a mango because they're related. So Mary Beth, do we want to check in with any questions before I move on to the next section?
Thanks, Marie. At this time, there are no questions in the chat box, but just as a reminder to everyone, Marie will be stopping periodically throughout. So if you do have questions that arise, please feel free to type them in the chat box, but we will be having a Q&A at the end also.
Okay, great, thank you. So let's talk about food allergens. So there are 9 foods responsible for the majority of food allergy reactions in the United States, about 90%. And you may have heard about the top 8 at FAIR, and now in a lot of places we're talking about the top 9 because of sesame. So the 9 foods that are causing most reactions are peanuts, tree nuts, milk, egg, wheat, soy, fish, shellfish, and sesame. And I'll talk a little bit about statistics for each of those in the next slide. But even though these are the most common allergens, a person can be allergic to absolutely any food. There's over 170 cases of people reacting to, or 170 different foods people have reacted to. So I know people who are allergic to avocado, people who are allergic to raspberries, people who are allergic to chicken. So you can be allergic to anything. These are just the ones people are allergic to the most and that you will hear about the most. And whether a person is allergic to an avocado or they're allergic to a cashew, it's still serious, and they should be treated equally in terms of how you manage and how you react. So these are the top allergens by the number. Everyone thinks peanut is always the top one, but it's not. It's shellfish. And this is a study, I think it was one of the Gupta studies. And by the way, I have a facts and statistics sheet with all of the data points and references. If anyone is interested, I will add that onto the sheet, or the information I send to Caitlin. But this is how it breaks down. This is the estimate. And you'll see shellfish is 8.2 million. Milk and peanut are 6.1 million each, not combined. I was just trying to save room on my slide. Tree nuts, just about 4 million. Egg and fish, 2.6 million each. Wheat, 2.4. Soy, 1.9. And sesame, which is not quite a million, but is emerging as a very common allergen. My son is born with a sesame allergy. I know a ton of people that have children with sesame allergies. I know a few adults with sesame allergies. If you are in a school setting, or if you're a school nurse, you probably have a student with a sesame allergy. If you don't, you probably will at some point. The challenge with sesame is labeling, and we'll talk a little bit about that in the labeling slides. FAIR has been working with the FDA the whole time I've been at FAIR to try to get sesame labeled, and we're actually getting very close. So the highest risk for developing food allergy. So even though we don't know what causes food allergy, we know from studies where we're seeing it more. And these are just a few statistics about that. Children from rural communities are less likely to have a food allergy than children from an urban area. And among inner city children who have a family history of some conditions like, hay fever, eczema, asthma, 1 in 10 of those preschool age children has an allergy to either egg, milk, and/or peanuts. So again, going back to that first bullet, we're seeing more in urban centers than we have more inner city children allergic to these items. And then childhood food allergy is increasing at a rate of 2.1% per decade among African Americans, but just 1.2% among Hispanics and 1% among white children. There's been a lot of talk about equity in food allergy care and food allergy diagnoses recently. We know from studies that Black children are at more risk for having food allergies and are getting food allergies more often. And FAIR recently started doing some work in this area and has got a roundtable coming up on equity in food allergy and inclusion and diversity, and what can we do to make these numbers not be higher for children who are Black or who are Hispanic. You know, what can we do? So that is something that is happening. There's information about that on our website if that's something you're interested in, and there are some more studies coming out in terms of diversity and equity in the food allergy realm. So how do you prevent an allergic reaction? Well, you have to avoid the allergen. That really is the only way at this point. There's no cure for food allergies. There's treatments that are coming up, like OIT I mentioned before. OIT does not cure food allergies, but it makes people what we like to call bite proof if they accidentally ingest their allergen after OIT. So the way to avoid the allergic reaction is you have to read labels all the time, every time, even if it's the same thing you've been buying every week. So as an example, there's a certain wheat bread that we've always bought, and I didn't take my own advice. I didn't look at the label. I got home, I looked at the label and saw that it now said, may contain hazelnuts. And at the time, my son, that was one of his allergens. And the week before, I didn't have that. So that's why it's so important to read labels every time, because they change. And legally, manufacturers are not required to notify the public if they change their formulas. Now, a lot will do that voluntarily, and they'll send information to FAIR. Starbucks is really good about that, and McDonald's and some other ones will ask us to put out an alert saying that they now have added milk to something or they've changed their formula. But the only thing that manufacturers are required to report are the labeling errors, or if something was inadvertently put into something and then not labeled. Be mindful of cross contact, and we'll go into that a little more coming up. And that's just taking a safe food and making it unsafe by different ways. And like I said, we'll talk about that. And dining out, you have to take special precautions when dining out and when traveling. And just because you have food allergies doesn't mean that you can't do things like dine out or travel the world. We have done that in my family. My son's been in Europe. He travels all over the country. He was just supposed to be on a school trip in Europe for 2 weeks from Prague to Milan, which did not happen because of COVID, and I didn't want him to miss out on that opportunity because he had food allergies. There's no reason, if you don't educate and take precautions and do planning ahead, that any of these things are not possible. The thing about dining out is that you really need to have a conversation with the waiter or with the cook. We have chef cards you can share that has information about your allergens. There are things you need to think about, like, does the food go into the fryer? If you have a shellfish allergy, you don't go to a seafood restaurant for dinner. If you have a sesame allergy, you don't go to Asian restaurants typically. So again, you can still dine out, you just need to take special precautions. And same thing with traveling. We went on a cruise. Cruises have actually been pretty good, and they go out of their way, at least the one we did, to keep people with food allergies safe. And always be prepared for an allergic reaction. And by that, I mean always carry 2 epinephrine auto-injectors, whether it's an Avi-Q or an EpiPen or one of the generics. Always carry 2. because one, you might need a second dose. Two, one might not work because if any of you have followed the news the past couple of years, they have malfunctioned. There have been recalls, at least on EpiPen. You just always need to be prepared.
Marie, we do have a question if you have a moment.
I hope I can answer it.
I think you will be able to. So the question is it known why African Americans have a higher risk to develop food allergies?
You know, I don't know the answer to that. I know that they're doing research into that, and there was a paper that was recently published, and I think there was a combination of family history, and also asthma had a part, like being part of the atopic march. I don't know if you've heard of that term, where children have eczema, asthma, and food allergies, and seasonal allergies, and they usually proceed one after another. But I can, as I said, that was just some published research, and I can get that information for you, because I don't want to quote anything that I don't know 100%. So let's talk a little bit about food allergen labeling. Even people who manage food allergies can find this very confusing, because the FDA, while they're, we're thankful that they have a protection act that requires manufacturers to label things, they let them label them in different ways. So they have options the way they can label, which can sometimes be confusing for people reading ingredients. So if you look at the two different labels there, that's the same food. And the one on the left here has what's called a contain statement at the bottom, where it has the allergen in plain language. If you go up into the ingredient list, you can see they have those same allergens, but not necessarily in that plain language. So for instance, you have whey, which is milk, and you have, I don't have my glasses on, sorry. The lecithin, which is soy, they're up here with a contain statement at the bottom. If you go to the other one, you can see that those same things are in common language within the ingredient list, but there's not a contain statement at the bottom. And what I have found when I get the parents who have called FAIR and said, so-and-so made a labeling error, they didn't put a contain, I didn't see it in the contain statement, I didn't see our allergen. The problem is they looked for a contain statement and then and didn't see it, so thought their allergen wasn't in it because they didn't read the ingredient list. So this is such an important thing to remember. What I do as a food allergy parent is, if I'm grabbing something, I look at the bottom, see if there's a contain statement, and then regardless, I still read the entire list. If I look at a contain statement and it says right away, cashew, pistachio, tree nuts, whatever, I know I'm not even gonna bother reading the rest. But people have to remember that the FDA can do this different ways, so they need to do both. They need to look at the whole thing.
Marie, we have another question before we get too far ahead.
Absolutely.
There's a question about carrying a second EpiPen, as you had mentioned.
Yeah.
And the question is, how would that work for low-income families?
Yeah. So this has been a big issue, because EpiPens at one point were, if you had a high deductible insurance, you were running $700, and people were, because they couldn't afford them, or they were on some kind of government program where they could only get one set, were dividing them up. It's not ideal. You really should never divide them up. However, we recognize that people have had to do this, or they're sending one into school and keeping one at home. It's just bad. It's better to have one than none, I will say. But there are programs, and I'm not pitching AviQ, and I'm not, you know, they're not sending me a check later. You can get free AviQ with their direct mail program. So that's one thing to do. And both EpiPen and the other company, which it was Impacts, but now it changed to a different name. That's like a generic. They offer coupons and different programs. So, you know, there are ways to get them for discounted costs. Unfortunately, the other thing that we see is that parents don't send their children with any epinephrine to school. And of course, it depends on the age, because some schools have stock epi. And it depends on your state and your budget and whether you have a mandate or it's voluntary. But if parents will say, well, I don't need to send epi with my child because the school has it. You know, I live in Connecticut. It's mandated here. My son, obviously because of his age, is carrying his epinephrine. He's self-carry. He's been for a long, long time. I wouldn't want to depend on the stock epi that may be locked up in a place way other side of the building. So it's tough. This is a long way of me saying there's no good answer, but there are ways that people can get epinephrine for a discounted cost or for free through AviQ. I hope that was helpful. And I can put that information on the stuff I'll send to Caitlin as well. So one of the things FALPGA, which is the labeling law, does not address, and people don't realize this either, is that advisory labeling is completely voluntary. So if you see something that says may contain, processed in a facility, made on equipment with, those are not regulated by the FDA. They're completely voluntary. And the fact that it's not there doesn't mean it's not processed in a facility. So, you know, our advice is if a person is concerned, if something is processed in a facility or made on equipment with, they call the manufacturer. And I think manufacturers now are used to getting those calls and may be able to tell a person, yes, we make that cereal on the same line as we make a cereal with wheat, but we do extensive cleaning and we wait 3 days, or you know, something like that. They can tell them, and then it's a personal decision with the family if what their comfort level is about eating food that has may contain or advisory labeling. There was a study years ago that showed that may contain statements. When they looked at the food, about is it 6 or 7% actually did have the allergen in it. And again, there's no law governing these, so the manufacturer can say the statement any way they want. You may have seen like made in a facility with, but uses extra special cleaning. You know, they go on and talk about what they do. So that's another thing. And FAIR has started working on with a committee on making this voluntary labeling better, more consistent, because again, it's kind of a free-for-all. Any questions, Mary Beth, about labeling before I move on?
No.
Okay.
Oh, wait, excuse me. Apologies. We're still asking about EpiPens.
Okay.
So definitely ensuring that we send out the AviQ information.
Yep.
And what is the recommended first-line treatment when EpiPen is not immediately available? I've always used oral liquid Benadryl, Zyrtec, Zantac. Has this changed?
We're actually going to get into allergic reactions shortly, so we can talk a little bit about that.
Great, thank you.
So just a little bit about cross-contact. It's not the same as cross-contamination, which is more of a foodborne issue, but cross-contact happens when one safe food becomes unsafe because it protein mixed with another. And even a tiny amount can cause a reaction. And this next slide here, I have examples of cross-contact, direct and indirect. So you can see here, you peel the cheese off a cheeseburger to make it a hamburger. That's a really bad idea because there's still cheese on there somewhere. Removing shrimp from a salad, and then scraping peanut butter off bread. I know you're thinking people don't really do this, but they do. And then indirect cross contact usually involves, using the same utensils without cleaning them, not washing hands after handling an allergen, and then not properly cleaning something that had been in contact with an allergen. So I don't think I need to tell this group that you should wash your hands a lot after you've touched anything in a food allergen, especially these days. Sanitizing gels in water don't remove an allergen. So a sanitizing gel acts more like glue. And I know in this new world of COVID, we're all using sanitizing gels all the time, which is fine. But if you want to remove an allergen, you need to use soap and water. And obviously, we don't want to share food, drinks, or utensils, because if somebody ate something and it's on their mouth is on the fork, or they've touched the fork or whatever, they've now shared that protein. So let's talk a little bit about allergic reactions. Every 3 minutes, statistically speaking, someone has a reaction. 25% of those are happening outside the home, and not surprisingly, teenagers and young adults are the highest risk of fatal anaphylaxis. And I would say, just anecdotally, they tend to be male. It's the boy brain, as I like to say, as the mother of a 17-year-old boy. So when allergic reaction happens, it's not just the typical hives, difficulty breathing. There's a lot of GI issues. There can be issues with the cardiovascular system, and a lot of other things. There's a chart next I will show you. And the symptoms appear usually right away, but they can occur within a few hours after ingesting the food. And a reaction can be mild or severe. And if you have a mild reaction once, it doesn't mean your reactions are always going to be mild. They can be mild, then severe, then mild. It can go back and forth. There's no way to predict what a reaction will be, and they don't get worse each time you have a reaction. That's a myth. And epinephrine is the only medicine that can stop anaphylaxis. Benadryl does not stop anaphylaxis. Now, Benadryl can ease some of the symptoms, but it cannot stop anaphylaxis, ever. This is some of the common symptoms. Excuse me. GI reactions are something a lot of people don't think of. And this, my son actually ate sesame at school in 4th grade and proceeded to vomit and feel really sick. And it was also during stomach bug season, and the school nurse, who I love dearly, did not recognize it as an allergic reaction. And he didn't know he ate something with sesame in it. And it wasn't until a couple hours later we figured out that's what it was, because I had given him something with sesame myself because I grabbed the wrong package. Just something to be aware of. It's not just the typical hives and things like that. So when there's an allergic reaction, when then you're looking at anaphylaxis, it's always epi first and then 911. Don't bother calling 911 first. Just give the epi. It's not going to hurt them. Call 911 and always advise epinephrine has been used. Now, I'm sure since many of you are in school setting, you have policies and protocols already in place for when there is a medical emergency like this. So as you know, they need to go to the hospital, and you may have to give them a second dose of epinephrine. One thing, depending on where you are, I'm in Connecticut, not all our ambulances necessarily will have epinephrine on them or have people trained to use epinephrine. So depending on where you live, you should always say that. So quality of life. Food allergy bullying is a big problem. We know 1/3 of kids are saying they've been bullied because of their allergies, and we know lots of them aren't telling us that they are. And the other things that are impactful are, a lot of parents don't let their kids do things that other kids would be able to do, like sleepovers or camps. So 25% don't let them 15% don't eat out, 10% avoid childcare or play dates, and 10% will decide to homeschool their child. Special demands on families. So if you see this little chart here, I don't know if you can see it, but the cost of allergen replacements, like for milk and for peanut butter and different things like that, can be up to 1,000% more. People who are already living in poverty are even going to have more issues trying to get safe replacements, especially for things like milk, wheat, and egg, and soy, which are in so many things. And the demands on families are always having to every year go through everything with the school. I'm filling out all my forms now. Again, senior year, I'm like, oh my gosh, I'm almost done. Filling out medical authorization forms and emergency care plans and this and that. Educating the new teachers, what to look for, etc. It can be really, affect your quality of life. And this is some psychosocial things here. You know, 70% of people with food allergy have had panic attacks. Parents, 90% of patients and parents have anxiety. 2/3 have mental health concerns. And this is a huge issue, the psychosocial issues related to food allergies. I mean, if you think about it, there are people who live in fear of dying if they eat something, especially if they've already had a reaction. And food allergies in the law. So you're probably familiar with 504s, and if you're in a private school, ADAs, or the ADA issues. But the ADA does say that people with food allergies may be covered, and it doesn't say will, it's may, because like with most laws, it's not black or white, it's gray. But the US Department of Education lists allergy as an example of a hidden disability for the purpose of a 504. And if you're interested in learning more about 504s, because that's a loaded gun, I don't like to use the word gun, but anyway, that's a loaded issue. There is going to be a webinar with someone who used to work for the DOJ in September that we're doing for free, and I'll send that information. So I'm just mindful of time, and I'm going to go through this quickly. It's a good thing I can talk fast. Because of you guys work at schools, most of you, I'm going to do some information that's specific about school. It's important for everyone who has a student to understand how to treat and recognize a reaction. And 1 in 6 children have had a reaction at school. So if you haven't already experienced that in your school, it's likely to happen at some point. And about 25% of these reactions at school have happened to people who don't even have a diagnosis of a food allergy. And that can include staff. Now, I don't want to forget that adults have food allergies too, and can have adult onset food allergies. So a teacher down the hall could eat something and have a reaction. This was an infographic. I want to talk a little bit about in the middle here. So 46% of reactions are happening in the classroom, just under 10% in the playground, and just 20% in the cafeteria. I always thought it would be a little more in the cafeteria than in the classroom. But, you know, this kind of shows you where things are happening. And school buses are an issue too, and depending on what state you live in, school bus drivers may be trained on administering epinephrine, and that happened in Connecticut last year or the year before. And I'm happy to share these infographics with everyone. Food in the classroom, this is a huge issue, and avoid use of food in curriculum. And we still have teachers who are using M&Ms for counting. And if a child has an allergy to milk or nuts, this is an issue. Don't use food as a reward. Kids like things like extra recess, or a no homework night, or letting them sit in a special seat. Always check the ingredients of arts and crafts supplies and science supplies, because many contain common allergens. A lot of paints are milk-based, so if you're dealing with little kids who are doing finger painting or any kind of painting, that's an issue. Wheat and egg are common allergens that are in arts and crafts supplies. make celebrations food free. I mean, how many issues do we have with children and food these days? We have diabetes, we have obesity, we have lots of other things. We don't need to have cupcakes every week. Think about doing something else. The parent sends in and donates a book, or for older kids, well, they don't celebrate birthdays for older kids, but think about ways to make those celebrations fun without food. And consider allergen-free classrooms as appropriate. Depending on the child, depending on the allergen, depending on their history, it may be appropriate to make an accommodation that their allergen is not allowed in the classroom. And that's done on a case-by-case basis. And as leaders in the schools, whether you're a teacher or a school nurse or administrator, you need to promote a supportive environment. You know, develop rules against bullying behavior. You know, if you see it, stop it. Encourage everyone to keep kids safe by washing their hands and bringing in safe snacks and different things like that. You can do education if it's okay with the parent, if the child or the parent want to come in and talk about what it's like. That helps, you know, peer pressure and reducing risk-taking behaviors and promoting safety, respect, and acceptance of somebody being different. When my son was little, we brought in Alexander the elephant has a peanut allergy, and by the time we got to 3rd grade, he told me I was not allowed to send that in anymore because he was too big for that. But we set up really great, what we did in kindergarten, 1st and 2nd grade has made his whole entire school life completely positive in terms of support from his friends. Social impact, social isolation. Don't do things that kids can't participate in. Besides it being illegal, it can really cause emotional distress. And bullying. And it's not just kids bullying. There have been teachers who have bullied kids, unfortunately. And that's very unfortunate. And bullying can be saying things, but it can be physical. There was a child in England killed last year when a boy made him eat a piece of cheese and he had a milk allergy and he died. So bullying is a huge issue. So I know this is important this year. We have food allergies and COVID, and we are going to school. Some of us are going different ways, but the CDC has come out with some recommendations, and FAIR actually worked with the CDC on their COVID recommendations. And these are some of them, you know, packaged food with labels, prepackaged meals instead of buffet style food. And some of the things I think are kind of no-brainers that you're probably already doing, like no food sharing or trading food, shouldn't be doing that anyway. Make sure staff is trained on recognizing and responding to a reaction, especially if food is going to be in the classroom this year. If lunch is going to move into a classroom, it's so important that everyone knows how to recognize and respond to a reaction. Washing hands, which I know we're all going to be doing a ton, and then limit the sharing of devices and books, toys, other items like that, which I think we'd be doing anyway, right, because of the virus. But these were, again, this chart here I have available, or this infographic on our page. And this has come up a lot. How do you tell if a little kid's having a reaction if their face is covered? So these are different ways children say they may be having a problem. You know, my tongue feels like there's hair on it. My lips feel tight. There's bugs in there, describing their itchy ears. Something's wrong. My tongue is hot. So these are all different ways children may describe a reaction. So be aware of that, especially with younger kids. You maybe won't see the things happening around their mouth. So we have a back to school headquarters. We have printable resources, the webinar series, blog posts, all things you can download for free. That's the URL. A lot of things I showed here are available on there as well. I know I'm 1 minute over, I'm here. And some resources that you may be interested in, new is Fair Check instructor training. So food service individuals in pre-K through college can get trained to deliver that training to all of the staff at the school in dining, and for free. The course, there is a cost for the course, but then the person can give that course for free an unlimited number of times. The next course is November 3rd. We have a free anaphylaxis training course, which is on demand. It's 15 minutes, and it shows how to use all the different epinephrine devices, including a new one, Syngenta, which is not an auto-injector, but it's a shot. Be-a-Pal, which is for little kids, more like pre-K through grade 2 or 3. And then our emergency care plan, which we have updated. If you use it for your school, we have updated it with Syngenta on it. And if this is my email at the bottom here, feel free to reach out to me. You can follow us on social media. You can join my collaborator program, which actually ASHA is part of. And basically, I send out a newsletter once a month with key resources, and I have one focused for educators. And that's it. Sorry, I had to speed up. I know we're at 11:53.
So yes, so Marie, we have a lot of questions.
Oh, yeah.
And so we have about 5, and so I'm hoping we can get through a few. Maybe you could stop sharing your screen.
Oh, sure.
And I can share mine, but as you do that, one of the first questions is, will labeling be asked to become law, or do parents need to advocate for that?
Labeling is a law. I'm not sure, was there something specific?
No, it just was asking if labeling is a law.
Yeah, so the labeling of the top 8 is a law. Sesame, which will be number 9, is going through that process. But those right now, those are what that's FALPCA, the Food Allergy Labeling Consumer Protection Act.
Great. Our next question is, if a parent says a child can eat food that says made in a facility, should we as school nurses allow that?
You know, it's a personal preference with the family. Some families do it, some don't. We don't in my house. It depends on the family. I can't say yes or no, because again, that's the family has made that decision on what they want or what they're allowing the child to eat. If you have a policy in place that says somewhere in writing that you don't allow that, you could certainly use that as, if you're not comfortable with that, or you can develop a policy that says something like that, but it really is up to the family.
Okay. If a child comes in with a food allergy and notices he had put something in his mouth and did not digest, his lips were swollen, and he has no other symptoms, should he be given the EpiPen?
So the rule of thumb is 1 severe symptom or 2 mild symptoms, you give Epi, and that's on our emergency care plan, which I can send to everyone too. So if it was just the lips, the protocol does not call for epinephrine, but if there was another one, like his eyes started to water or there was a hive, absolutely. So it's 2 mild or 1 severe.
Okay. I've had one patient's parent state their FPIES started.
FPIES.
Thank you. Started dramatically after receiving the 5-in-1 vaccine, and one patient whose parent stated her child's severe allergies is linked to the use of several antibiotics as a newborn. Is there a connection with triggers to allergies developing, poor gut health, or immunosuppression?
So I don't know about the vaccine and FPIES. There's been no link to food allergies to vaccines, or at least, there's been no research that shows that link. But you had a great question about the gut. There's a ton of research going into how the gut and the microbiome has impacted the number of food allergies, and does it cause food allergies? And my son was given antibiotics at 2 days old. So that's in the back of my mind as well. It's definitely something they're looking at, and they are seeing correlations with, they can't say for sure, but they're seeing correlations with antibiotic use and other issues with allergies. So yes, more to come on that for sure.
Then EpiPens must be available in our schools. Severe allergy could pass at any time. EpiPens can save lives. Why can't they have them in their emergency first aid kit, at least one, independent of students who are recognized with severe allergy and keep their EpiPens at a clinic? So is there the ability to keep EpiPens more on a person in a first aid kit instead of in a clinic if we know that they save lives?
Right. So we recommend children who are old enough and have their doctor's permission should be self-carrying anyway. Usually the nurse has to sign off on that. Little kids typically aren't allowed to self-carry, but there are actually state laws that will say whether, so a child can self-carry but can't inject, or they have to know how to inject to self-carry. It really varies by law, but I agree, any child who's old enough to self-carry should self-carry, and that has to get signed off by the physician and the school nurse to carry in school. My son has always self-carried since probably 4th or 5th grade. He went to a really tiny school, so I wasn't concerned about access to the epinephrine in the office. But yeah, check what your state law is in terms of self-carry. Every state allows self-carry, but there are different rules about who can self-carry.
And we'll try to get in this last question.
Okay.
Can you provide an EpiPen to a person who does not have an EpiPen? Like they have allergies, they have a reaction. Can you use another person's EpiPen?
Well,
on them?
Yeah, I mean, I think if you're talking about saving someone's life, you know, you do what you need to do. A lot of times, you know, it would depend on what the laws are in the state, but I think that would cover as Good Samaritan, because, you know, and I'm assuming you're not talking about stock epi, because stock epi you would be covered from liability, and that wouldn't be an issue. But if I was to take, you know, I always carry my son's ABQ with me, even when he's not with me, because I'm ready to save someone if I need to, because people have reactions and don't know they have allergies. So I would check just with the Good Samaritan laws in your state. I don't want to say for sure that it's okay or not because I'm not a lawyer.
Great, I think we got through them all. Thank you, Marie.
You're welcome.
So thank you everyone for joining us today. As we mentioned in the chat, the resources and the materials that were shared today are going to be emailed out to everyone and posted on ASHA's website, and along with the recording of this webinar. You can receive continuing education credits. There's one continuing education hour that is made available from you attending this webinar. And you can get the CHCH from NCHEC. You can get a NAP contact hour for your participation. Also, members receive free continuing education credits, and you need to complete the webinar evaluation in order to receive these CEs. So please make sure to fill out the evaluation at the end of this. We have some upcoming webinars on the 10th of September around breast health with the Get in Touch Foundation, and on the 22nd of September, engaging youth in a comprehensive school physical activity program. And with that, here is ASHA's website, phone number if you have any questions. Again, thank you for joining us today, and thank you, Marie, for providing some really valuable information around food allergies.
Happy to.
Yes, and the evaluation should be provided to you once you exit out of this webinar. So thank you so much, and have a great rest of your day.
And also the evaluation will be sent out in the follow-up email to everyone who attended today. So keep an eye out for that within the next day or so. Thank you all.